So thank you for those who have joined. So this evening's presentation will be recorded and will be available on our website later on for viewing. So before we get started, I'll just very briefly point a few of the features out to you. You should be all able to both see and hear me. If at this stage you can see the slides but cannot hear me, make sure the audio on your voice on your device is switched on and working. We'll be using the online chat to interact. So what I'm going to do now is I'm just going to send you a very short message on the online chat so that you will see where it's coming up, hopefully. So if you could all just find your online chat there. And perhaps just introduce yourselves very briefly, just your name, and we'll know then that we're communicating with each other. We'll be using the online chat to interact, ask questions throughout the seminar. So if you could just on your screens find where there's an online chat, I'll send in another message because it might pop up for you, and just enter your name. Susan, have you got your online chat there? Maybe if you just enter your name, we'll know it's working. Excellent, Susan. Okay. You might want to just unmute yourself there, Susan.
There we go. Perfect. All right. Hello.
Okay. Anybody else able to see the online chat? Excellent. There's one other person after joining in. Anyone else got their online chat? Okay, so just for those who are joining, we're just getting started. Emma Wallace, unfortunately, is ill, and Susan Smith is in today. So excellent. Catherine is after finding the online chat. So the last thing I want to say is we have GCP point for this webinar, and after the webinar, we'll send you on a certificate. We know who'll have LinkedIn for us. So at this stage, all I'll do is pass you over to Susan. So Susan Smith, VP at Inchicore Family Doctors and Professor of General Practice at RCSI, has kindly stepped in at very short notice. She's an outstanding track record as a researcher of international renown, particularly focused on multi-morbidity. Before I pass over to her, I might just say if you could all check that your mics are muted. There's somebody coming in with some background noise. So yeah, if we could just check that only Susan should be on speaker. Okay, so Susan, over to you.
Okay, thank you very much. Apologies that I'm not Emma, and I hope that she'll be feeling better soon. But we're all just back from a big meeting in the States and in Canada actually, and I think probably her immune system was low, but her toddler gave her the winter vomiting bug, which is not a pleasant experience for her. So I'm going to speak this evening about managing multimorbidity in general practice with a particular focus on evidence-based approaches. And it's great to see a wide range of I can see some GPs there, and I suppose I'd particularly like to welcome Catherine Nicholson, who's actually dialed in from Canada, that we met at the meeting last week. So thanks, Catherine, for joining us. This is what I'm going to talk about. I'm going to look very briefly. It's not really going to be much about multimorbidity prevalence and definition. I'm going to focus a fair bit on the challenges for patients and healthcare providers. And I'm going to look at what's the evidence that can support our management at the moment and recommendations for practice. So we could do a whole webinar on the definition of multimorbidity, and you'll be glad to know that I don't think that would be a good idea. People talk a lot about what it actually means, and I think it's now accepted that it really is just two or more chronic conditions in the one individual without having any particular prominence. So the idea of comorbidity really is that there would be an index condition. In this being systematic reviews of the prevalence studies, it varies hugely from setting to setting, depending on how you define it and how you count it. In Ireland, about 60% of people over 50 who attend GPs have multimorbidity. But of course, that means it's nearly the norm in middle-aged and older adults, but not all multimorbidity is equal. and there's more of a focus now on what's called complex multimorbidity. So people maybe who have 4 or 5 or more conditions, who are on lots of medicines. As I think for GPs, they're the particular group that they find difficult to manage. The evidence for effective interventions is, there's some evidence, but it's quite limited. And there's a lot of research now on the challenges, particularly that patients experience living with multimorbidity. So looking first at the challenges for patients, well, there was a great paper published in the BMJ a couple of years ago that looks at what's called minimally disruptive medicine, and it introduced the concept of treatment burden. And you can see that cartoon there at the top is taken from that paper. And essentially what it says is that in some cases, some of the treatments that we are suggesting for people are more burdensome than their original conditions. And that's clearly a crazy situation for us to find ourselves in. Another slide there talking about the types of experiences patients have in coordinating their care. And then, of course, multimorbidity, particularly complex multimorbidity, is really related to polypharmacy. So I'm going to just get everyone, making sure everyone's still awake at the end of a long day. And the first question that I want you to, perhaps in the chat thing, you can give your answers, is I want you to have if you know, it's great, but otherwise have a guess. What proportion of people over the age of 65 years in Ireland do you think are on 10 or more regular medicines? Is it 5%, 15%, 25%, 40%, or 60%? And I'll give you a hint, it's the same as it is in Scotland and England, but I don't know so much about Canada or other countries. So if you wanted to just
you should be able to find the online chat there and enter your guest answer. If you hover over the bottom of your screen, good. So 1 or 2, excellent. So we have a few answers coming in, 25%, 40%, 15%. Okay, bit of a range, Susan.
Okay, well, I think Eamon O'Shea is the guy who's done his homework on this one. So it is 15%, which is really, a phenomenally high number. That's of everyone over 65 is on 10 or more medicines. So this is some very interesting work that was led by a postdoctoral pharmacist in our research centre, Frank Moriarty. And he looked at the trends of polypharmacy over the last 10 to 20 years in Ireland. And you can see, if you look at those graphs, if you look at the graph in 1997, the orangey purple colours are the higher numbers of medicines. So you can see that it was quite uncommon in 1997 for anybody to be on more than 10 medicines, even as they got older. But you can see this phenomenal expansion in 2012 to the point now where about 15% are on 10 or more medicines, but 5% of people are on 15 or more medicines. So we really have had an explosion in polypharmacy, probably driven in part by clinical guidelines. And this is not just uniquely Irish, it's the same picture in other countries such as Scotland and England that have measured it in a similar way. So what are the evidence-based approaches to managing multimorbidity in general practice? Well, about a few years ago now, we published a clinical review that was led by Emma in the BMJ with a focus on what evidence was there to say to clinicians managing multimorbidity. So it was very much the clinical focus, but it took about a year to write this review. The BMJ editors were very tough on us in terms of that every suggestion we made had to have some kind of literature behind it or evidence. So I think in the end, because of their pushing us, we were able to come up with, I think, reasonable clinical guidelines for clinicians. So in terms of the challenges for GPs, there's 3 key areas. The first is around the disorganization and fragmentation of care. There's the difficulties with chronic disease management when patients have multimorbidity. There's the challenge of delivering patient-centered care when we have such short consultation times and we're so short on resources. And I'm going to start now by looking at the disorganization and fragmentation of care. So one of the difficulties we have is our electronic records or software systems don't automatically identify that somebody has complex multimorbidity. And that's partly because we've designed our health systems and our record systems around single conditions. We have real challenges with continuity of care. I think it's really important to look, I think GPs often, we consider continuity in terms of our relationships with patients, but continuity of care has three elements. The first is in fact about our ongoing relationships that we build up over time with patients. But we also need to have continuity of information, and that's not just about GP information, it's also information that patients are, that relates to patients in specialty settings, other settings such as pharmacy. And then there's also this issue of managerial continuity of care, who is responsible for coordinating care for these complex patients. And you really have to get all three of those right to provide true continuity of care. And there is evidence from the literature that continuity of care with the same GP improves preventative measures and it reduces preventable admissions. The big, all the research with GPs is that they say they need more time for these types of patients. And that makes sense given the complexity of managing them. And both GPs and patients, and this links, I think, to lack of time, talk about suboptimal communication, but particularly between providers for patients. And I think sometimes patients think that we're all in far better communication than we are. But as we GPs know, we're waiting all the time for letters to arrive in. And we're always seem to be a step behind in terms of information with these complex patients. So what are the recommendations for practice if you look at that evidence? Well, the first thing, it's nearly a conceptual thing really, is that you stand back and you think, hang on a second, this isn't just this patient who has all these problems. This is a patient who I am now going to decide has complex multimorbidity, and I'm going to change the way I manage them as a result of that decision. Now, how do you define complex multimorbidity? Well, you could say there's an Australian study where they've defined it saying that it's multimorbidity involving more than 3 body systems. I think that's based on the fact that people who have conditions from different body systems are usually seeing different specialists, which does make things very complicated. The work from Scotland suggests that when you have comorbid physical and mental health conditions, outcomes are much poorer, and it's much more challenging to manage that combination of conditions. We know, looking at patients who are prescribed more than 10 medications, there's very strong correlation between significant polypharmacy and significant multimorbidity. And of course, other groups such as our housebound or nursing home patients would usually fall into that category of complex multimorbidity. So once you've decided that that this patient has complex multimorbidity, you might decide that, well, I'm going to assign a named doctor to provide usual care for this patient. I think in many practices in Ireland at the moment, we sometimes assign a named doctor when we're having trouble with a patient and a practice is experiencing difficulty with a high attender or frequent attender. But actually, we probably could use assigning a named doctor more often than we do. Now, I'm talking from the perspective of somebody working in a 3 to 4 partner practice. So it would be obviously very different in a single-handed practice where you already have this situation. And once you've decided that you're going to have that named doctor to provide usual care for the patient, obviously with the patient's involvement in this decision as to who that named doctor should be, you then might decide that you're going to have specific extended consultations with the patient. And it may in fact be more appropriate to do this, and you may see the patient less overall if you try and structure or organize their care. And so, for example, you may bring them in to see your nurse first for bloods and blood pressure checks, and then they come back in to see you. You may also decide that you're going to look at their conditions and decide and monitor them more rationally. Do they really need to see all the specialists that they're seeing? Perhaps every time they go back to a clinic, they just see an SHO who really can't discharge them. So it goes on bringing them back in. And maybe sometimes we can say to patients, it's actually at the moment we can manage your diabetes or your COPD. It's very stable. Now, I'm saying that in the context of lack of resources and lack of an appropriate GP contract in Ireland, and I'm very conscious of that. So I'm just hoping that the new contract will address these issues. And then the final thing that you can decide that you're going to do that is a kind of a non-disease specific thing is doing a medication review, because medication reviews are relevant no matter what the underlying combination of conditions are. So if you're going to do a medication review, you might want to focus on what's called potentially inappropriate prescriptions. So these are our prescriptions where the harm of the prescription may outweigh its benefit. That may be because the medications have particular adverse effects, but it also may be because the medications aren't working. And obviously an ineffective medication doesn't have any benefit. So people have developed these indicators or screening tools for people who have to look at potentially inappropriate prescribing. And probably the one that we would know most in Ireland is the STOP tool that was developed down in Cork. They developed it with colleagues in the UK. And they have 65 criteria that you can apply to a prescription and decide what are potentially inappropriate prescriptions. And they include, prescriptions where there might be drug-drug interactions. They look at the clinical indication. They look at the duration of treatment and the dose optimization. So another question just to keep you going. What proportion of Irish patients with a GMS card are prescribed a potentially inappropriate prescription over the age of 65? What's the prevalence of PIP in over 65s in Ireland on the medical card system? If you want to just add in into the chat. For those of you who are new, you might want to just open up your chat and you can put whichever answer you think it is.
Okay. So maybe 37%, Susan?
Yeah, I think you've all done your homework very carefully. Yes. So that's a paper that was published again by Tom Fahey in our centre, and it was the baseline of the study that Emma Wallace was doing. So it is 37%, which again is similar to figures in the UK. So this was research that Emma did for her PhD, and it looks a little bit more at potentially inappropriate prescribing. And what was interesting with this was a 2-year prospective cohort study, and very few people had looked at the long-term outcomes of PIP. So that's what Emma was looking at in her PhD. So she had 904 patients over the age of 70 from 15 general practices in the Leinster area. So that's a province in Ireland. They were all community dwelling. They had baseline data collection, and PIP was identified using the STOP criteria, and we were able to link their prescriptions in general practice to the national dispensing data set, that the GMS prescriptions. The primary outcome, so we were interested to know whether potentially inappropriate prescribing or PIP would have an effect on adverse drug events, but also whether it would impact on health-related quality of life for patients, and whether it would be related to emergency admission and emergency department visits. So the overall findings from this research was that actually, similar to the national research, the baseline, the prevalence of PIP in these 900 patients was 40%, a little bit higher than the national average, but then these are people over 70 rather than over 65, which probably explains that. Very interestingly, all the patients, there was telephone interviews carried out with patients, and it was a very elaborate process to work out whether they had adverse drug events. And once they described symptoms, then independent GPs decided whether those symptoms were likely to relate to their medications. And what we found was that the prevalence of patient-reported adverse drug events was really high. It was 74%. So 74% said that they were getting significant adverse effects from the medicines that they were on. And the most frequently reported adverse drug events were easy bruising, urinary frequency, ankle swelling, and myalgia. So the incidence of severe adverse drug events was actually very low, thankfully, as one would expect. But there was a high prevalence of what would be called more minor adverse drug events. And then what Emma found was that if you had more than 2 of the STOP PIP criteria, that you would have a significantly higher future adverse drug events, that you would have poorer quality, health-related quality of life, which was a clinically significant reduction in quality of life. You'd have higher numbers of accident and emergency visits, but no association with emergency admission. So, I mean, what's interesting about this is that probably what's affecting people's quality of life is that high prevalence of what we would call minor adverse drug events, but they're clearly having quite an impact on patients' well-being. So what this research tells us is that you could use this kind of approach to identifying PIPs using STOP as part of your medication review with the patient with multimorbidity. So another question now. These are indicators from STOP. So anyone who's ever used it before will probably know the answer to this, but otherwise have a guess. So the question is, which one of the following of these is a potentially inappropriate prescription according to STOP? Is it an oral NSAID for longer than a month? PPI, proton pump inhibitor at a maximum dose for greater than 2 months? Aspirin prescribed without a proton pump inhibitor cover? Benzodiazepine for longer than 2 weeks? Or opiates prescribed with a laxative? So you can stick your answers into the chat there.
Susan, while people are thinking, almost everyone has a mic. Would you like me to turn on the mics at this stage and allow people to talk?
I'm very happy to do that.
Okay, I'll unmute everybody, and if anybody wants to mute themselves again, they can. So just if you want to speak your answers or ask a question as we go, you can.
Yeah, please feel free to stop, to interject and ask any questions if you want to.
And if anyone wants to turn on their video, they can as well, Brian.
Okay, so we have 30, where are we there? NSAIDs.
And PPI at max dose.
Yeah, okay. Eamon is winning so far. He's right on all of the answers. NSAIDs are obviously a real, safety kind of concern at the moment, but within STOP, the indication is actually for longer than 3 months, interestingly. So the only one there that is actually a STOP PIP is proton pump inhibitor at maximum dose for longer than 2 months. So you're meant to reduce them to a maintenance dose after 2 months. Aspirin only needs to be prescribed, or a proton pump inhibitor only needs to be prescribed with aspirin if you've had a history of peptic ulcer disease or if you're on an NSAID. Benzos are actually allowed for up to 4 weeks, which I'm surprised about. I thought you were in trouble after 2 weeks. And then obviously the last one is a trick. They're meant to be, it's inappropriate to prescribe an opiate without a laxative. So sometimes people are a bit less bothered about the indicator of a proton pump inhibitor at the maximum dose going on and on. It clearly has quite a lot of economic impact because they're expensive drugs. But interestingly, there's more and more research emerging about the potential adverse long-term effects of, high-dose proton pump inhibitors in terms of gastric cancer and various other issues. I guess, like all things, it may well come around that this will be something that we'll be concerned about more and more going into the future. So I'm going to look now, the next area that's a challenge for GPs is around chronic disease management. So clearly we know that our clinical guidelines tend to be based on single diseases. They rarely address multimorbidity. And if they do, they usually write a sentence at the bottom that says, oh, by the way, most people have multiple conditions and you should take that into account, which isn't particularly helpful. Unless it's integrated throughout the guideline, it's not going to be useful for a GP for somebody with multimorbidity. And we also know that the evidence underpinning a lot of the clinical guidelines is based on RCTs that routinely exclude patients with multimorbidity. So as a clinician, what we have to realize is that individual recommendations for each condition in the clinical guideline may be sensible, but the sum of all may not be. So again, I'm going to look, this was a very nice paper that was done by colleagues in the UK, Bruce Guthrie and his team, and they had a hypothetical 78-year-old female patient, and they decided she had a relatively common set of conditions: ischemic heart disease, diabetes, osteoarthritis, COPD, and depression. And they applied 5 UK clinical guidelines to her. So the next question is, how many medications is she likely to be prescribed if you follow the guidelines? And then the other one as well, how many GP visits per year? So if you want to, if your mics are unmuted, feel free to have a guess at that.
Or you can use chat.
Or you can use the chat if that's easier. We haven't really done one of these with the mics off before because it could get a bit chaotic. Okay, I'll go on to the next slide. Does anyone want to have a guess at how many medicines? Okay, here it is. So she's prescribed at least 11 with the potential for another 10 medications depending on how much of a, yeah, you can right there, David, 12, depending on how aggressive you are in terms of following the clinical guidelines and trying to really bring her risk factors under control. But not only will she be prescribed at least 11 medications, she'll be asked to engage in at least 9 lifestyle modifications. So we kind of tend to throw them out to patients. Oh, by the way, you need to exercise, you need to, you know, eat such and such food, you need to reduce your alcohol. But
Sorry, Susan.
All right. She'll be also advised to attend about 8 to 10 primary care appointments per year and another 8 to 10 secondary care appointments. And then she may also, on top of that, when she sees one of these primary care or secondary care doctors, they might say, oh, you need to see one of our multidisciplinary team members. So there could be an unending amount of activity for this patient, really to try and manage all of her conditions. So last year, the NICE, the guidelines body in the UK, published the world's first multi-morbidity guidance, and it's a really, really useful document. It highlights the value of clinical judgment, that really what we have to do is prioritize maximum treatment benefit rather than pursuing disease targets. But if we're going to start practicing like that, we're going to need awareness from policymakers that such trade-offs may represent better patient-centered care. So it may not be appropriate to have somebody's HbA1c very tightly controlled for their diabetes if they are struggling with very severe arthritis or whatever, you know, other conditions that may impact on their glycemic control depending on the medications used. So this is a screenshot of the multi-morbidity guidance. It's very easy to access, and everybody in Ireland, I think, can access that free. This is a kind of an algorithm that they talk about adults with 2 or more long-term health conditions, and they take you down through these various steps. There's a lot of overlap with frailty and assessing frailty, and it's got some good guidance on how to do that. But essentially what it's talking about is delivering an approach to care that takes account of multi-morbidity. So if you don't have time to read the full guidance, here's a summary. What the guidance really focuses on is a discussion of disease and treatment burden. So that when you've identified your patient as having multi-morbidity, you actually sit down with them and you go through them. What are their current disease burden, so their symptoms, and their treatment burden will be stuff around the amount of appointments they have to engage in, how many medications they're on. And then, having done that, you might want to look at a patient's personal goals, values, and priorities. They may prefer to be pain-free, to have more quality of life, and be less concerned about their renal function. Now, clearly, these are all trade-offs, and I'm not suggesting that you could ignore somebody's renal function completely and give them a non-steroidal indefinitely. But it may be that we sometimes have to be a bit more flexible about how we manage things based on patients' priorities. And that having done that, you'll develop and agree an individualized management plan, and you'll agree what actions will be taken first. So you may decide during your medication review, there's a whole other literature, and the last webinar we talked about it a little bit on deprescribing, so stopping medicines for people with significant polypharmacy. You might decide to prioritize their healthcare appointments. You might assign responsibility for coordination of continuity of care, and you know, we've said earlier, we think that should probably be the person's GP, and then arrange a follow-up and a review of decisions made.
Susan, there's a question there on chat you might like to take.
Sorry, okay. So what formula you use to calculate the number of meds per disease, as this depends on the attending clinician? Are you referring there to the guideline paper? Okay. Presumably you are. So that was the paper that we talked about where the woman was on 5 conditions. And what they did was they literally looked at the clinical guidelines for each condition, and they applied what were the recommended treatments. Now, clearly it was a kind of an exercise that was hypothetical, because some clinicians will, and that's why they said there was a potential for a few more medicines, because it would depend on how aggressive a clinician was, and all of us do differ in how much we chase risk factors, the hawks and the doves among us. So you're right, it does depend on the clinician. So the last challenge for GPs is the need to deliver patient-centered care. And how do we do that, particularly in our system in Ireland, where we have so much pressure on us and so little resource to do this work? So the big discussion really around the literature is around shared decision making. This is really about bringing patients into the conversation about what's going to be the best care for them. That this shared decision making, if it's based on patient priorities, all the qualitative literature with patients with multi-morbidity talks about how they really want to be able to have better daily functioning. So you may decide that instead of targeting disease risk factors, you're going to try and work on function. How do we make it so that this person can get to the shops more successfully, or is able to go out with their family? And for that, you may well need to engage with other members of your team, such as occupational therapists or physiotherapists, to help manage these things. There's also a fair amount of evidence around self-management for long-term conditions, and people do certainly promote it a lot. But the research evidence for self-management support, particularly for what are non-disease specific conditions, is really quite limited. And what the evidence suggests is that lay support groups are probably beneficial for patients who are particularly interested in attending them. But when you apply them to the general population, there's much less evidence that they're successful. So what are the recommendations for practice? You could start by deciding at the very beginning in your patient with complex multimorbidity to ask a very general question: what's bothering you most, to prioritize care that will have the most patient impact. Consider your multidisciplinary community team members. I've certainly, we've done a fair amount of work that's mainly research now with occupational therapists, and they do an extraordinary amount of stuff around managing fatigue, managing day-to-day activities. And in Ireland, most community OTs spend all their time getting devices for people for their homes, and it's such a waste of their skills, given that they're generalists like we are. And it is worth offering condition support groups for patients who might be interested in attending those groups. So a summary, so this is a recommendations for practice for GPs. The first thing is to identify that a patient has complex multimorbidity, assign a named GP for continuity of care, remember the value of clinical judgment, that guidelines that are disease focused won't always be useful for you. Prioritize what you're going to do. It could be a medication review. It could be management of mental health difficulties if a person's mood is their main problem, and you might want to look at optimizing function. There's no doubt but that this will require extended consultation time, and this is something that everybody acknowledges and needs to be resourced adequately in all healthcare systems. So what's the evidence then? We're into the kind of the final section now, and I'm kind of conscious that we've probably only got about 10 minutes left, and we can certainly have some questions then. So what's the evidence about managing multimorbidity from the research area? Well, we updated in 2016. We've got a Cochrane review of interventions for multimorbidity that we've been doing since about 2007, and it was updated in 2016. What this review, it has 18 studies in it. All of them are randomized controlled trials. 9 of them focus on specific comorbid conditions. So these are the studies that we call the depression plus studies. So it would be if you had diabetes and depression, or ischemic heart disease and diabetes and depression, or hypertension and depression. And then the other 9 RCTs focused on a broad range of conditions, but mainly in elderly people rather than in, we know that actually multimorbidity is equally prevalent in middle-aged people. 12 of the studies looked at organizational intervention, so things like case management or adding another team member, such as a pharmacist or a case manager, to provide multidisciplinary support. I think everybody thinks this should work, because one of the issues with multimorbidity is this idea of the chaos and the fragmentation of care. But there's no evidence at the moment that organizational interventions work. And there was an interesting presentation I heard where a GP was saying how one of his patients came in and you know, they had just assigned case managers to all their very complex multi-morbidity patients. This was in a practice in London. And the patient came in to see the GP the next week and said, yet another person has called to my house. I've no idea who this person is, and I'm sick of telling everyone everything that I'm on and what my problems are. So there's no point in adding new organizational steps to somebody's care unless we rationalize what they're already having. And maybe that's why some of the interventions haven't been effective to date. There were 6 of the 18 studies that had patient-oriented interventions. So they either had educational or self-management type of support. And there wasn't, again, very strong evidence for these in this patient group. Now, the majority of the studies only lasted 6 to 12 months, and that's probably not long enough for many of these interventions to have an effect, to be fair. And maybe if they ran over longer periods of time, it would be better. So what the review showed was that there was very little difference in clinical outcomes. The mental health outcomes clearly improved, and that's all driven by the comorbidity studies with depression. There's now nearly overwhelming evidence from this review and from several other Cochrane reviews that stepped care for depression works, and really we just have to implement it now in practice. So that's models where people with mild depression are managed in a primary care setting, and then it's gradually stepped up if they're not responding to treatment involving nurse specialists and then finally psychiatrists. There was some small improvement in patient-reported outcomes around functional ability, very little or no difference in health service use, and some improvements in provider behaviour in terms of prescribing, which is interesting because that would be something that would take longer to come through. But again, what we're saying is that actually 18 trials from the world is not a particularly large amount of evidence. So there will be more studies coming on stream over the next year or two. So these are the trials that are currently reporting that weren't in the Cochrane review. There's a very important one from Scotland called the Care Plus study. And this was actually only a pilot RCT. It just had 100 patients in it, but it was a very difficult trial to run. They looked at middle-aged people in the most deprived parts of Glasgow, and they introduced a system-level intervention with extended consultation times. They assigned named GPs, so they had relational continuity. They put in a lot of practitioner supports, and they also had a lot of patient supports and signposting to community services and mindfulness and lots of different approaches for the patients. And what they found is that it significantly improved patient well-being and quality of life. And their economic analysis for that showed that this intervention is cost-effective at a cost of £12,000 per quality adjusted life year gained. Now that's how the NICE and other kind of fund guideline bodies and health economists would judge a health intervention. And actually that would be regarded as a highly cost-effective intervention. They're meant to fund all interventions that cost less than £20,000 per quality adjusted life year. But obviously this hasn't been funded, and I think they're going to try and do more research to push this into practice more. There's another very large study that's going to report in the next 6 months called the 3D study. This is a study led by Chris Salisbury from Bristol, and they also had centres in Manchester and in Glasgow. They had 1,500 patients in this trial, so it's a really big and important general practice study. And what they did was they had an organisational approach and care coordination. They improved continuity of care by having a named doctor and a named nurse. And they replaced their normal reviews with what they called patient-centered reviews. And they had a focus on the dimensions of health, so quality of life. They wanted to reduce treatment burden. They did depression screening, and they did drug reviews. So we're hoping that this study, which we'll be reporting shortly, I think in the next few months, will show that this type of approach is helpful. Then looking at Ireland, we have a randomized controlled trial that's nearly finished recruiting, I hope in the next 2 to 3 months in Dublin. This is an interesting study where we have occupational therapists running these self-management support groups. So the patients get the benefit of peer support in the group, but they're also getting the benefit of the group being professionally led. So it's a little bit like the model for cardiac rehab and pulmonary rehab, where there's strong evidence that they're effective. But we've designed this to address multi-morbidity so that it's for everyone with every condition. And we did a small pilot trial of this that was published that was very promising and showed really significant improvements. So we hope that will persist in the main study. And then finally, another trial that's nearly finished recruiting practices, but we haven't started the interventions yet, is the SPIRE study. And I think some of you may well be signed up to this in your practices, and thank you very much if you are, and if you're not, please consider it. We need probably, I think we're down to needing about 4 or 5 more practices. We need 42 in total. So actually we've had an incredible response from Irish GPs, because I think they realise this is something that really matters to them in practice. So this is a trial targeting people on 15 or more medicines, and they have a web-based medication review that we have designed to try and support a multi-morbidity focus and to encourage de-prescribing in this patient group. So in summary, I think we probably can accept that multi-morbidity is the clinical norm in general practice. Particularly, we're concerned about complex multi-morbidity, so the people who have more conditions, higher numbers of medications. We are the people who still have a generalist approach, and I think that this is really the area for GPs to step up and to manage. But we will absolutely have to be resourced to do that. It is not going to work in our current chaotic system, where we're lucky if we have 10-minute appointments with patients. And that we would have, our skills are such that we'll be able to adopt a patient-centered approach and prioritize patient outcomes. So there are some evidence-based recommendations to support practice, but of course, all of this does depend on health policy and the choices that we as a society make in our health system around how we're going to resource general practice going into the future. So I'm very happy to take questions. If anyone wants to ask anything or make any comments.
And Susan, we do have the one question in earlier from Eamon O'Shea.
Oh, yes. Sorry, Eamon. Thank you very much. I know you emailed a question earlier. I don't know whether you would like to elaborate on that question, because it was around training, GP training and multi-morbidity. I see you've got your mic muted, Eamon, if you wanted to.
Mute, yeah.
Yeah.
Can you hear me okay now, Susan?
Yeah, perfect. Yeah.
Thanks very much for that talk, Susan. It was excellent. Yeah, I work on the Western Training Programme in Galway.
Yeah.
And for the last several years, I've been, through my own practice, been interested in multi-morbidity, because I think it is the biggest single issue for us working as GPs.
Yeah.
And have, I suppose, in a sense, struggled to develop a module for my group of registrars.
Yeah.
So I'd be interested in your views. I think for trainees in practice, they find general practice can be daunting enough. And ironically, they actually see the complex multi-morbidity patients quite frequently, because some of these guys are people who are frequent flyers, and they see the trainees.
Yeah.
But they feel really overwhelmed and daunted. And when I've tried to, so I developed a program where we had small group work with trainers, first of all, to brainstorm, and then we did some work with the trainees, and we get them to follow one patient throughout their year, and we do some small group work to talk about that during the year. And I suppose I try and bring them back to Emma and yours recommendations on the BMJ article, which is what we started off with. But I have to say, they still struggle a huge amount.
Yeah.
Well, I suppose the biggest issue is time.
Yeah, it really is. But I couldn't agree more with you about, I think we have to deal with it, because it's such an issue for us. I interested in a session 10 days ago with the GP registrars on the RCSI scheme. And it was very similar to the session I've done now, but obviously because we were face to face, there was a little bit more interaction. And there were 3rd and 4th year regs, and I'd say half of them in the room were really engaged, and the other half did seem to me to be very overwhelmed by it, actually. Which was an interesting experience. So I think a one-off session is probably not great. So it's brilliant that you've got this idea of continuity around your education. They did. I totally agree. They see these people more because of, particularly the frequent attenders. Now, Sarah McGuire, who's an assistant program director up in Donegal. I don't know if you know Sarah. Sarah.
Yes, I know Sarah. Yeah.
She did something very similar and has published on it. And if you email me, I can but you a link to that paper. So they designed a workshop on multi-morbidity that was very case-based. But I think it was a one-off. I don't think they did this continuity. Now, I had a GP who was doing a master's with me 3 years ago, and we actually did a systematic review of educational interventions for doctors for multi-morbidity. And we found 2 studies in the whole world that have ever evaluated an education program. Partly that's because sometimes they're not calling it multi-morbidity. So there's probably a fair amount of work in medicine for the elderly around complexity and medicines reviews that would be very relevant to multi-morbidity. But certainly, I mean, I work in a fairly deprived area, so I'm actually nearly more concerned about the middle-aged people because, first of all, I've very limited specialist support for managing them. And at least in the older patients, you've got the geriatricians or the medicine for the elderly who will back you up a bit, and you've got one point of contact. I don't know what your experience is about that.
That's true. And also geriatricians by their nature generally tend to be more generalist and more sensible about guidelines, whereas your middle-aged group are more likely to see the gung-ho cardiologists and etc., who will be more guideline-based.
Yes, exactly. Yeah. So it is a difficulty. But I think, I'd love to hear more about your program and how you're going to evaluate it. And hopefully you might present it at a college meeting or something. It'd be great this is the kind of thing we need to be doing. And I think that the college I know is thinking about this, and we've just started to engage on around a kind of a quick reference guide. But I mean, I think it's much more about experiential learning, because there isn't one set of answers because these patients are so varied. The people need to just develop skills that, are generic across different multi-morbidity patients. And it's that kind of systematic approach to care. It was we did a qualitative piece with GPs several years ago, and it was a great quote, which was that you bite off one bit of the elephant at a time. And, if you accept that that's what you're going to do, it becomes it's less stressful for you, because you stop trying to do everything at one point in time, and you accept, well, today I'll do this, and then next time I'll do something else.
Okay, so Susan, I wonder if there's any other anybody else. I'm just conscious our time is moving on.
Yeah. Does anyone else want to maybe make a comment or say anything?
You can use your chat, or you can unmute yourselves. Okay, so big comment coming in there, Susan, from Catherine in Canada.
Okay.
Right, okay.
Okay. Okay, so what Catherine is saying, well, the electronic tool thing is interesting, okay? Are you talking about to identify patients with multi-morbidity, Catherine? If you take off your mic if you want, if you unmute yourself, if you want to. Oh, are you talking about putting, like capturing patient-reported outcomes that you then put into the electronic record, is it? Yeah, I think I was at a meeting in the States a few weeks ago where it was a meeting about quality of life measurement, and there's a huge move in the States to use kind of IT, so like you might have apps or tablets in your waiting room, and patients fill out, quality of life measures, and then when they come in to see you, you're all ready to go with their knowing whether they might have already been screened for depression, or whether what their well-being and quality of life is like. That these have great potential to make a more patient-centered consultation, but the other issue is they also, certainly one of the primary care doctors at the meeting stood up and said he himself was actually, I think, about 70, and he said he now was on his 4th primary care physician, because one of them had died young from overwork, 2 of them had retired early, and there was one left just hanging in. So primary care physicians in the States are absolutely overwhelmed by the bureaucracy of their jobs. And they have so much after hours administration that actually one of the concerns, if we start introducing all these extra outcome measures, is what will happen. You know, it has to be something that will make everybody's life better rather than adding to bureaucracy.
And there's another question here, Susan. Is there any course you'd recommend on medicine for the elderly?
I amn't personally aware of any good ones. I know the College of Physicians does them. And I don't know whether I don't think the Irish College of General Practitioners specifically does one. If anyone else knows, they feel free to put up a comment. And the slides will definitely be, actually the recorded webinar will be available and the slides can be available as well. Yeah, and Adele has put that in there.
Okay, so I think,
yeah.
Susan, probably just, we should wrap up now. For those who joined late, you are in the right webinar. Emma Wallace was taken ill today, yeah. So Susan Smith very kindly stepped in. So I think on behalf of everybody who joined this hour of the evening, Susan, a really big thank you. People had registered beforehand and it was great that you were able to deliver the slides or deliver the webinar for Emma. So we'll leave it there. We'll send you on your CPD certs, and I would be interested if you have any feedback on the nature of the webinar or the content or the present, how it's presented in terms of technology. Drop us an email, and also if you have any topics you would like covered in future webinars, just let us know. So thank you very much to Susan and to everybody for joining.
Okay, nice. Have a good evening. Bye.